Welcome to this module in which we will be discussing patients with special challenges. Upon completion of this module, you should be able to list the types of abuse found in the pediatric and geriatric populations, summarize the assessment and management of pediatric and elder abuse patients, explain the legal ramifications of failing to report abuse, describe the documentation needed for abuse patients, relate to patients with sensory defects, and utilize enhanced communication skills. Prepare to interact with the developmentally disabled patient. Give examples of health issues for which the bariatric patient is at increased risk. Recognize the increased planning necessary to move bariatric patients. Identify technology-assisted or dependent equipment used by patients. Explain what a tracheostomy is and the routine and acute care which may be necessary. Describe the interaction with patients being provided health care at home. Summarize the concept of hospice and the EMS role with patients under hospice care, and identify the potential assistance that can be provided for homeless patients. You should also be able to explain the rationale for having skills and knowledge appropriate for dealing with patients that have special challenges. Recognize the importance of including family members and other healthcare providers in the assessment and management of patients with special challenges. Attend to the feelings of the family when dealing with patients who have special challenges, and understand the provider's own emotional response to caring for patients with special challenges. Lastly, you should be able to demonstrate the assessment of a patient who has sensory or cognitive deficits. To begin, our first group of patients with special challenges are those who are victims of abuse and neglect, namely children and the elderly. Abuse refers to the intentional harming, mistreatment, neglect, or exploitation of a child or elder by a parent or caregiver. The actions of the parent or caregiver may threaten harm, have the potential to harm, or actually result in harm. It is important to remember that these patients, children and elderly, can be more vulnerable to abuse because of their dependence on others. Abuse comes in many forms, occurs everywhere, and crosses socioeconomic boundaries. Statistical data on child abuse and neglect is included in the trauma overview module of this course. The types of abuse encountered by the pediatric population include neglect, physical abuse, sexual abuse, and emotional abuse. Neglect occurs when the caregiver fails to provide for the child's basic needs. This may include the failure to provide food, shelter, personal hygiene, comfort, or safety. Signs of neglect may include a child that appears thin and underweight for their age and height, a child that is dirty or unclothed, a child that has lack of appropriate supervision, or a child who does not receive medical care when necessary. Child abandonment is also considered a form of neglect in some states. Physical abuse is non-accidental physical injury that occurs when physical force or violence is used, regardless of whether it was intended to cause pain, injury, or harm to a child. Signs may include bruises in various stages of healing, bite marks, burns, or fractures. Infants have the highest risk of dying as a result of such abuse. Sexual abuse can occur to children of any age or gender. Many times the offender is a parent, relative, or someone the child knows. This type of abuse may not be as obvious as neglect or physical abuse. More information on the signs and symptoms of this type of abuse is provided in the trauma overview module of this course. Emotional abuse, also called psychological abuse, damages the child's emotional development and often diminishes their feeling of self-worth. It is difficult to prove, but is usually present when other forms of abuse are found. When assessing a patient that is being potentially abused, begin with the scene size-up. What does the scene size-up reveal about the environment? Is the scene safe for EMS providers to enter? In many instances, EMS providers are the only ones who see the patient's home environment. Emergency room personnel or social workers must rely upon information and documentation provided by EMS personnel. Think about the patient's living conditions. For example, is the environment safe or dangerous, clean or unsanitary? Is the home extremely hot or cold? Is there food in the home? Is there any evidence of alcohol or drug use? You should do a full assessment of the pediatric patient as you learned in the pediatric module. Remember when doing your ABCDE assessment to not forget the exposure step. Clothing can hide objective findings of child abuse and neglect. Also remember to respect and preserve the child's dignity. For example, the EMT can ask the child if he or she can listen to the child breathe. This gives the EMT the opportunity to assess the patient's back and chest for injuries or other trauma. When obtaining the history and performing a physical exam, ensure the story is consistent with the injuries sustained. If the information provided is that a 3-year-old was sitting on a short stool before falling onto a carpeted floor, such a fall is unlikely to result in unconsciousness or seizure activity. There may be more going on in such a situation. The same could be said for a 9-year-old who fell off a bicycle at a low rate of speed onto some grass, presenting with a black eye, fractured forearm, and multiple bruises in various stages of healing on the chest and back. Those findings are arguably supportive of suspected physical abuse. At that point, the EMT has a legal obligation to report the suspected abuse to law enforcement or other appropriate agency. Along those lines, consider if the injury is typical given the child's developmental age. For instance, a 1-month-old lacks the strength necessary to roll over on his or her own. If the story is that the infant rolled over and out of bed on his or her own, resulting in a depressed skull fracture, the EMT should be suspicious. During interactions with the caregiver, the EMT should try to determine if the caregiver is acting appropriately given the circumstances. Does the caregiver appear concerned about the child's well-being, or does the caregiver seem to lack empathy or concern? On the other hand, does a caregiver appear to be over-concerned? Is his or her behavior strange or unusual? Does a caregiver simply not interact with the child, or does a caregiver appear to be under the influence of alcohol or drugs? Does the caregiver's story change? Keep in mind the timing of the call itself. Was there a delay in seeking medical treatment? For instance, if the child has second-degree circumferential burns to his legs that, according to a caregiver, occurred several days ago when the child was stepping into the bathtub, such a delay given a significant injury of that type is arguably unreasonable. Be sure to observe how the child and caregiver interact with each other as well. Does the caregiver refuse to allow the child to talk, answering all the EMT's questions even when those questions are directed toward the pediatric patient? While some parents and caregivers are overly protective of their children, does this particular caregiver seem to be a little too protective, refusing to leave the child alone with the EMS crew even for a moment? Are there any nonverbal clues, looks, or other body language that may infer a threat from the caregiver to the child, such as a look from the parent to the child that he or she should not speak with the EMTs? In some instances, an abnormal relationship or interaction between the child and caregiver may appear obvious to the EMS crew. In other instances, any tension or abnormalities may be subtle or unperceivable by the EMS crew. Another further complication engaging this type of interaction is that children may still prefer to remain with an abusing parent or caregiver rather than leaving to be with a complete stranger, such as an EMT. When performing a physical assessment, be aware of different injuries and injury patterns. Does a child have different injuries in various stages of healing, such as bruises, burns, or bite marks? Does a child have unusual marks on the body or various types of injuries? As an example, a pediatric patient with a combination of burns, bruises, fractures, or bite marks may be suffering from physical abuse. One such injury of this type may be common, but a compilation of different types of injuries within a short time frame are much less common to be explained as simple accidents. Bruises, scratches, or other injuries to protected or unexposed parts of the body, such as the back, buttocks, or face, could be suspicious, as everyday play will commonly not result in injuries to those areas of the body, as opposed to those that occur on the arms and legs. While the problem of child abuse and neglect cuts across racial, ethnic, socioeconomic, and other boundaries, cultural differences can play a part in the types of injuries sustained by abused children. Hmong families, for instance, use coining, cupping, and pinching as forms of medicine. They believe that these practices help with drawing pain out of the body. These practices can also leave marks or bruises on the body that would appear to be from abusive behavior. It is also not uncommon for bruised areas to be drained, as they believe the process releases toxins that would otherwise cause illness. If there is an unexplained decreased level of consciousness, the EMT must try to identify a cause. If there does not appear to be a medical or accidental trauma explanation, abuse, such as shaking a baby, may be to blame, as head injuries are somewhat common in abuse cases. Lastly, any unexplained genital injuries could be indicative of sexual abuse of the child. In such cases, it is not unusual for the child to be withdrawn, frightened, or unwilling to discuss what happened with an EMT. In these instances, documentation and preservation of evidence is very important. Be certain to follow your local protocols and involve law enforcement if any abuse or neglect, including sexual abuse, is suspected. The management of a child abuse victim begins with gathering information and completing a thorough assessment. As an EMS professional, remember to stay calm, keep a professional composure, refrain from making accusations, and collect data without passing judgment on others. You must remain objective at all times, and do not attempt to turn or pit the child against their parents or caregivers. Also, do not indicate to the parents or caregivers that you suspect abuse. EMS providers are not physicians. They are not experts in recognizing or identifying abuse, and it is not in their purview to presume or assume, especially given circumstantial evidence findings. Suspicions and surrounding objective findings and facts must be reported to law enforcement or other appropriate agency for further investigation. Preserving evidence is also important, especially if sexual abuse is suspected. In such instances, the child should not be allowed to wash, urinate, defecate, brush his or her teeth, or change clothes until examined in the emergency department by someone trained in forensic evidence collection. In many instances, law enforcement may already be involved and can assist or even take the lead in ensuring the proper collection of evidence. As with any patient, be certain to perform a complete assessment of the patient and provide medical care as necessary for the child. If abuse is suspected, it may be prudent to transport the child to an emergency department, even though the injury by itself may not warrant the transport. If transported, ensure all appropriate child safety devices are utilized. If you feel the child needs to be transported and the caregiver refuses, contact your medical control and local police agency as needed. As covered in the trauma overview module of this course, Wisconsin law enforcement officers have the legal authority to take affirmative steps for the protection of the child. EMTs in Wisconsin are required by law to report suspected child abuse to law enforcement or other appropriate agency depending on the resources available within the specific area of the state. Telling the emergency department staff does not fulfill this statutory obligation. There are also legal ramifications, discussed in the trauma overview module of this course, for EMS providers who fail to report child abuse. Appropriate, objective, factual, and comprehensive documentation is of paramount importance for child abuse and neglect cases. For every patient interaction, it is important for EMS providers to paint a picture of the call, so to speak, in the narrative section of the patient care report. EMS reports relay information to other healthcare providers, become part of the patient's permanent health record, are used for continuous quality improvement (CQI) activities, and are discoverable and admissible in future legal proceedings. For these reasons, it is very important to record all information completely, accurately, and objectively. Report all objective findings, including pertinent negatives, and do not include opinion or conjecture. Following these guidelines is even more important in cases of suspected child abuse or neglect. Remain objective and do not allow personal feelings or emotions to taint the patient care report. Professionalism exhibited on scene must also translate into professionalism when documenting the call in the patient care report. In these cases, it is important to provide a thorough description of any injuries discovered during the assessment process, including the location, size, and color of the injuries. For instance, if the patient has a burn mark that appears to be caused by a cigarette, the injury itself should be described objectively by including the dimensions of the injury, the color and appearance of the skin, and the location of the injury in respect to nearby anatomical landmarks. If the patient states that it is a cigarette burn, it is okay to document as such, but be certain to reflect that the patient did indeed state it was a cigarette burn. Without that clarification, the patient care report may give the impression that the EMS provider determined it was a cigarette burn, which is an opinion the EMT may not be legally qualified to make. Along those lines, any statements made by the patient caregivers or others on scene pertinent to the patient care report should be included in quotes along with documentation indicating who made the statement. Keep HIPAA requirements in mind as well. Confidentiality is important, even more so in cases of alleged abuse, as unfounded allegations can create a societal stigma for the accused individual. As with any other patient care report, be certain to document why EMS was called, patient's chief complaint, medical and social history findings, assessment findings including physical assessment findings, detailed description of injuries, environmental findings related to the environment in which the patient lives or was found, and statements made by and interaction observed between the patient and caregivers, medications and allergies, interventions taken by the EMS crew, any external agency involvement including law enforcement, who assumed patient care at the receiving facility, and the details associated with mandatory reporting, which EMS crew member reported, to what agency, and what specific person. Unfortunately, child abuse and neglect occurs with frequency in our society, with serious life-threatening injuries, permanent disability, or death being the final result. If abuse is not reported by those who suspect it, the child is likely to continue being abused. Legal obligation aside, EMS professionals have a moral duty to protect those who cannot protect themselves and report suspected child abuse to law enforcement. Proper documentation is a component of that process. Elder abuse includes any action or form of mistreatment that results in harm or loss to the older person. This includes taking advantage of the person, his or her property, or failing to provide basic needs if that person is dependent on others. Abandonment, whereby an individual with legal custody of a person deserts him or her, can also be a form of elder abuse depending on the state. Like child abuse and neglect, elder abuse and neglect exists in many forms and occurs everywhere, even across socioeconomic boundaries. The scope of the problem is also difficult to quantify due to suspected underreporting of elder abuse and neglect. Geriatric patients, such as with dementia or other medical condition affecting their cognitive abilities, may not always realize they are the victims of abuse or neglect. There is also a propensity in our society to overlook the geriatric population or assume any claims regarding abuse or neglect are somehow inaccurate, given a faltering perception or understanding that can sometimes accompany the aging process. As with child abuse and neglect, the offending party is oftentimes a close family member. In some instances, the abused elder patient tolerates the behavior because he or she is dependent or does not want to create problems within the family. The elderly person may not report abuse even if they know it is occurring due to feeling ashamed, guilty, angry, or frightened. They may fear no one else will care for them. Elderly patients who are frail, depressed, have sensory impairments, multiple medical conditions, or disabling illnesses, such as dementia or strokes, are at greatest risk for being victims of elder abuse and neglect. These individuals are commonly dependent on others for everyday activities of daily living, and their routine care needs may even exceed the caregiver's ability to meet them. It is important to remember elder abuse occurs in multiple settings such as private residences, senior or assisted living facilities, and nursing homes. Neglect occurs when the caregiver fails to provide for the patient's basic needs. Physical abuse occurs when trauma is intentionally inflicted. Pushing, shoving, the use of chemical or physical restraints, or unreasonable confinement can all be precipitators of physical abuse. Signs may be obvious, such as multiple injuries in various stages of healing. In other instances, the signs may be more subtle or hidden. As always, remember to keep patient dignity in mind, and if exposing the patient to conduct an assessment, be certain to ask the patient's permission and let him or her know what is being done as a part of the assessment process. Remember as well to not be judgmental, make accusations, or jump to conclusions. Sexual abuse is physical abuse that involves the individual's reproductive and sexual organs, including the genitalia and anus or rectum. Injuries to the genitals or rectum without an associated report of trauma should be regarded as suspicious and reported. Any non-consensual sexual conduct is not only considered sexual abuse, it can also constitute the crime of sexual assault up to and including rape. Emotional abuse commonly includes making threats, isolating the person, or creating fear by verbal or nonverbal actions. This type of abuse can be difficult to identify, so be certain to listen attentively to the patient and take their comments seriously. One of the most common forms of elder abuse is financial abuse. This occurs when the elderly patient's funds, property, or other assets are inappropriately acquired, converted, obtained, or utilized by the abusing party. Pharmacologic abuse is another form of elder abuse that may occur, whereby the abuser absconds with the patient's medications, commonly for personal use or to sell, especially in the case of narcotics, or utilizes medications against the elderly patient to perpetuate other forms of abuse. As with any assessment, begin with the scene size up. Ensure the scene is safe to enter. If responding to a residence, does it appear to be well kept or dilapidated? Once inside the living area, is it dangerous or safe, clean or unsanitary, very hot or too cold? Is there evidence of adequate food in the residence? Is there evidence of alcohol or illicit drug use? Are the utilities, water and electricity working? If necessary, are appropriate assistive devices present or available? Remember that other healthcare workers or social services staff may not have the opportunity to see the patient's home environment. This glimpse into the elderly patient's living environment is very important and should be documented thoroughly as necessary. When conducting an assessment, ask questions and listen attentively. Allow the patient to communicate at his or her own pace. Do not rush the patient to complete a sentence or thought. Some geriatric patients do have cognitive disabilities that can make it difficult to communicate effectively, however, so keep that in mind as well. Try to obtain an explanation from both the patient and caregiver as to what happened to necessitate EMS involvement. Observe the patient's behavior. Engage whether or not it is appropriate for the situation. If the patient appears fearful, depressed, is reluctant to answer questions with the caregiver present, or looks to the caregiver for approval while answering questions, there may be cause to suspect potential abuse. Observe the caregiver as well. Is the caregiver impatient or hostile to either the patient or the EMS crew? Does the caregiver provide a conflicting or changing story, or work to impede or prevent the elderly patient from speaking openly with the EMS crew? Throughout the assessment and treatment process, some questions to keep in mind when trying to gauge the potential for abuse include: is the story consistent with the injuries sustained? Do the injuries match the mechanism of injury? Have there been repeated EMS calls to the residence for the patient or ED visits? If so, is there a pattern forming, or can a pattern be identified? Multiple falls or other injuries should be investigated further. Does the patient have a history of being accident-prone? Are soft tissue injuries present? Does the patient complain of chronic pain? Is there evidence of unaddressed health issues or problems such as bed sores, for instance? Does the patient suffer from eating or sleeping disorders, depression, inactivity, self-destructive behavior, or substance abuse? Does the patient have a history of being sexually abused? Behaviorally, is the patient passive or withdrawn, displaying signs of helplessness or hopelessness? Or does the patient seem overly aggressive, possibly as a result of being mistreated by others? As an EMT, it is essential to complete a thorough assessment and gather as much information as possible. Verbal responses as well as nonverbal clues are important to note. Gathering information through the assessment process is important for piecing together the clues that may lead an EMT to suspect elder abuse or neglect. If sexual abuse is suspected, do not allow the patient to wash, urinate, defecate, brush his or her teeth, or change clothes until he or she is examined in the emergency department or evidence of a sexual crime is obtained by someone trained to collect such evidence. If abuse is suspected, the EMS crew may decide to transport the patient to the emergency department even if the immediate injury may not warrant transport by itself. Remain professional, refrain from making accusations, and do not pass judgment on others. Treat any injuries and medical conditions per your service's EMS guidelines and protocols. If you feel the patient needs to be transported given suspected abuse and the patient or caregiver refuses, contact medical control and seek assistance from law enforcement. Additionally, there are more protections in the law for abused or neglected children than the elderly, so there may be instances in which it may not be possible to mandate transport of the elderly patient, even with law enforcement involvement. If elder abuse is suspected, however, the EMT is still legally obligated to report the findings to law enforcement. Having law enforcement involved on scene in such instances can prove to be beneficial. In Wisconsin, EMS providers must report cases of suspected elder abuse to law enforcement or other appropriate agency, depending on the area of the state. Sharing this information with emergency department staff does not fulfill this statutory obligation. A failure to report suspected elder abuse may result in legal ramifications for the EMT, so it is in his or her best interest to report suspected abuse to law enforcement. As always, thorough, accurate, objective documentation is an absolute must in these instances. Documentation is important for every EMS patient contact, but the critical nature of accurate, thorough, objective documentation is even more pronounced in cases involving suspected elder abuse or neglect. Similar to documenting cases of child abuse or neglect, be sure to keep the following points in mind. Be complete and accurate in recording all observations and data. Report objective findings. Do not include opinion or subjective information. Document detailed descriptions of any injuries, including their size, color, other appearance, and location on the body. Do not assume the cause of injury. Do not make conclusions or accusations. Be certain to include the name of the source for any information provided. Use quotations if including statements provided by various people present at the scene, and maintain confidentiality at all times. When documenting assessment findings and interactions, remember to include the following on the patient care report: nature of the call, why EMS was called; patient's chief complaint; medical and social history findings; physical and environmental assessment findings, including detailed description of injuries and statements made by others or interactions observed between the patient and caregivers; list medications the patient is taking, along with any noted allergies; any and all interventions provided by the EMS crew or others on scene. Include who assumed patient care at the transport destination facility, or, if there was no transport, why there was no transport, and what directions were provided to the patient or caregiver by the EMS crew, and to which agency and whom the suspected elder abuse was reported. Elder abuse is prevalent in every community and, unfortunately, continues to grow as the population, baby boomers in particular, continues to age. As an EMT, you will be in a unique position to evaluate the patient's home environment and possibly detect abuse before it escalates to life-threatening injuries, disability, or death. Unreported abuse will typically continue. Legal requirements aside, for the sake of the patient, EMS providers have a moral obligation and professional duty to report suspected abuse to law enforcement or other appropriate agency. Another population facing unique challenges from an EMS perspective are the homeless and the poor. Homelessness and poverty exist in all communities across all racial and ethnic groups. For the purposes of this discussion, homelessness is defined as not having a regular place to live or the inability to maintain safe or suitable housing. Poverty exists when a person's income, or that of his or her family, does not allow for the maintenance of basic needs, such as nutrition, food, adequate shelter, or clothing. Poverty can also be defined locally as being below a socially accepted standard of living. Poverty can ultimately lead to homelessness, and it is also common for a person in poverty to lack adequate health care. When caring for homeless or poverty-stricken patients, the EMS professional must advocate for patient rights and appropriate care. Far too often, the poor or homeless are shunned by society and, in some instances, healthcare providers. The EMT must serve as an advocate for his or her patients, especially those who are disadvantaged or unable to advocate for themselves. The EMT should also proactively identify facilities or organizations that can provide treatment and care for patients who lack the financial means to pay for those services. This is important because a lack of health care and disease prevention can result in a higher risk for the transmission of communicable diseases. Those living in poverty, including the homeless, are at increased risk for malnutrition, substance abuse, pulmonary infections, tuberculosis, HIV, AIDS, and other ailments. They also commonly lack personal hygiene and health maintenance, such as routine dental care, adequate exercise, and proper nutrition. EMS providers interfacing with this population must educate as to healthcare options and community resources available to assist them in maintaining a minimal level of acceptable health. EMS providers should treat all patients with dignity and respect, which obviously includes those of lower socioeconomic status, such as the homeless or poverty-stricken. In many instances, these patients will feel vulnerable, embarrassed, or even ashamed of their circumstances. Regardless of their personal circumstances, these patients deserve the same respect, care, and consideration afforded to those who may be more affluent. Bariatrics is a discipline of medicine that studies the causes, prevention, and treatment of obesity. According to the American Heart Association, in 2012, approximately 1 in 3 children ages 2 to 19 were overweight or obese. 1 in 6 were considered obese. Among Americans aged 20 and older, 149.3 million were overweight or obese. 75 million were obese. Bariatric patients are at greater risk for developing significant health problems such as diabetes, hypertension, heart disease, stroke, sleep apnea, or respiratory problems, to name a few. If these trends continue, the American Heart Association reports that healthcare costs attributable to obesity could reach more than $900 billion by 2030, which would account for approximately 17% of all U.S. health expenditures. From an EMS perspective, bariatric patients present with very unique challenges given their physical weight and size. First and foremost, it is important for EMTs to treat all of their patients, including bariatric patients, with dignity and respect. It is not the EMT's job to judge the patient based upon his or her appearance or the reasons associated with the patient's obesity. With that being said, it is also important for EMS providers to consider safety in all aspects of providing patient care. When working with bariatric patients, that means ensuring adequate resources are available to assist in properly and safely moving the patient. In some instances, the patient may be able to ambulate on his or her own. There are also other times in which the EMS crew must physically move the patient. Utilize common sense in determining whether or not the current resources on the scene are adequate for such a task. For instance, it is probably not feasible for a two-person EMS crew to move a 400-plus pound unconscious bariatric patient. Ensure adequate personnel and equipment is available to safely move the patient. Doing so not only provides for the safety and well-being of the EMS providers, but it also protects the patient from being dropped by the EMS crew. If the patient is conscious, be sure to communicate with the patient so that movements can be coordinated. While proper body positioning and lifting mechanics should be employed by the EMS crew in moving any patient, it is extremely important when moving heavier patients. As far as additional resources are concerned, some EMS services actually have specially equipped bariatric ambulances designed to accommodate obese patients. Throughout your assessment and care of the bariatric patient, be ever mindful of the patient's positioning. Given the patient's size and amount of adipose tissue, fat, respiratory compromise can occur somewhat easily. In some instances, bariatric patients cannot breathe adequately if placed on their backs. Some hospitals have bariatric facilities available, so keep that in mind when selecting a transport destination for the patient. When providing a report to the receiving facility during transport, it should be noted when a bariatric patient is being transported so the facility can prepare for receipt of the patient. If additional help is necessary to remove the patient from the ambulance upon arrival at the facility or to transfer the patient to a hospital bed in the emergency department, be certain to request that assistance from the facility as soon as possible, which can also be done while providing the report to the hospital during transport. One of the current trends in medicine is to treat and release patients as soon as possible, meaning that more patients are receiving ongoing care at home. With that being the case, it is no longer unusual for EMS providers to respond to households for patients with tracheostomy tubes, ventilation devices, apnea monitoring, pulse oximetry, long-term vascular access devices, intravenous pumps, dialysis devices, pacemakers, cardiac defibrillators, insulin pumps, neurological shunts, urinary devices, left ventricular assist devices, or gastrointestinal devices, to name a few. We will be discussing some of these technologies in greater depth shortly. If confronted with an unknown or unrecognized medical device in the field, the EMT should not hesitate to contact his or her medical control for assistance. Keep in mind that patients with these devices, in addition to their caregivers, are typically very well versed in the use, maintenance, and troubleshooting of the specific device. These individuals can be invaluable in providing assistance when managing a patient dependent on one or more of these medical devices. Ventilation devices are used in patients that cannot breathe without assistance. Common ventilation devices an EMT may see in the field include tracheostomy tubes and ventilators. Ventilators are machines that move breathable air into and out of the lungs for patients that are unable to do so sufficiently on their own. If a ventilator malfunctions, the family or caregiver is commonly able to troubleshoot the device. If a problem with a ventilator cannot be corrected, the EMS provider should disconnect the ventilator and manually ventilate the patient. Apnea monitors are designed to alarm if an infant stops breathing. Such an occurrence is called an apneic episode. These monitors usually include electrodes or a belt that is wrapped around the chest or abdomen. Pulse oximetry is a non-invasive method to measure the binding of specific gases, typically oxygen, to hemoglobin within the blood. While most ambulances carry pulse oximetry devices, they are also becoming prevalent in the home for both pediatric and adult patients who require monitoring of oxygen saturation within the blood. Keep in mind that just because a pulse oximeter denotes a high percentage of oxygen within the blood, it is no guarantee that the oxygen is being adequately perfused to the tissues. Additionally, carbon monoxide within the blood will be read by pulse oximeters as oxygen, thus skewing the reading in instances where carbon monoxide is present in the environment. In all instances, remember to treat the patient, not the specific monitoring device, given a thorough assessment and ongoing reassessments. A tracheostomy tube is a plastic tube that is placed directly into the trachea after a surgical opening is made from the anterior neck. The opening created for the tracheostomy tube is called a stoma. The tracheostomy tube may have a single cannula or a double cannula, which has an inner and outer cannula. Routine care includes keeping the stoma clean and dry. At the EMT level, there is not much that can be done if problems exist with a tracheostomy tube. The Wisconsin EMT scope of practice in place at the time this presentation was created does not allow for tracheobronchial suctioning at the EMT level. If a tube becomes blocked or dislodged, a higher level ALS provider should be utilized to take additional interventions. There are a number of patients EMS providers may encounter that have long-term vascular access devices. These devices may also be referred to as central lines, central catheters, or by the specific type of device, such as a MedPort or PICC line. A vascular access device is a flexible plastic tube or catheter that is placed into a blood vessel for routine blood draws, medication or nutrient administration, or a combination of all three. These devices are usually located on the anterior chest or upper arm. A few complications associated with these devices include infection, catheter occlusion or damage, and hemorrhage. If bleeding is an issue, the EMT should control the bleeding with direct pressure and follow his or her protocols for hemorrhage control. Dialysis devices may be seen in patients with renal failure or a history of renal failure. These devices are implanted to assist with hemodialysis, which is a treatment that cleans the blood by removing waste and excess water from the body. These devices are referred to as hemodialysis shunts, grafts, fistulas, or central dialysis catheters. The dialysis grafts or fistulas are usually located in the upper arm, while the dialysis catheters are usually located on the chest. Only advanced level providers with special training can access these devices. Pacemakers and automated implanted cardiac defibrillators, AICDs, are devices that are implanted under the skin with electrical leads running into the heart. A pacemaker functions to regulate a person's heart rate, and a cardiac defibrillator monitors a patient's heart rate and delivers defibrillation shocks as necessary to terminate potentially fatal rhythms, such as ventricular fibrillation. These devices are usually implanted under the skin in the chest or abdomen, with a noticeable bulge resulting in the area. If an EMT needs to apply defibrillation pads to a patient with a pacemaker or AICD, be certain to not place the pacing or defibrillator pads directly over these devices. A left ventricular assist device, LVAD, is a mechanical support device designed to help the heart pump blood through the body of patients with severe heart failure. While the device name refers specifically to the left ventricle, it can assist the function of both ventricles. For patients the EMT may see in the field, the device is usually implanted in the abdomen. Patients with such a device are commonly advised to alert their local fire department or EMS service if they will be returning home with an LVAD. As an EMS provider, your primary responsibility will be to provide basic care and support measures to these patients. Remember to utilize the caregiver as a resource while on scene and possibly during transport if the caregiver will join the patient on the ambulance during transport. Advanced life support should be utilized if available to assist in the appropriate care of these patients. A shunt placed for neurological conditions is a tube that extends from the brain to the heart or abdomen to drain excess cerebrospinal fluid, CSF, and prevent it from accumulating around the brain, which, in turn, prevents an unsafe increase of intracranial pressure within the skull. A ventriculoarterial shunt drains excess CSF from the ventricles of the brain into the right atrium of the heart. A ventriculoperitoneal shunt drains excess CSF from the ventricles of the brain into the peritoneum of the abdomen. It is typically possible to feel the device beneath the skin on the head behind one of the ears. These patients are at risk for infection, blockage, or some other malfunction of the shunt. If the CSF is unable to drain appropriately or adequately, the patient will likely begin exhibiting the signs and symptoms associated with increased intracranial pressure. Gastrointestinal devices that may be encountered in the field by EMS providers include colostomies, ileostomies, and feeding tubes. A colostomy is when a surgical opening is made in the abdomen wall, typically on the left side, and a section of the large intestine is attached to the opening. An ileostomy is similar to a colostomy, with the exception that a piece of small intestine, as opposed to large intestine, is attached to the surgical opening, typically on the right side of the abdomen. These procedures may be required to treat medical conditions such as ulcerative colitis, Crohn's disease, or cancer. The opening created is referred to as a stoma, which allows for the elimination of waste products, stool. An external bag or pouch collects the waste products and must be emptied by the patient or caregiver. Patients with these devices are at risk for infection and can suffer skin irritation where the colostomy or ileostomy bag is attached to the skin. Follow local guidelines and protocols for care and treatment of patients with these devices. EMS providers may encounter patients of all ages who rely on medical devices for their nutritional support. Feeding tubes may be temporary or permanent. Some of the main types of feeding tubes include nasogastric, gastric, and jejunostomy tubes. Nasogastric NG tubes are passed through one of the nares down the esophagus into the stomach. Gastric G tubes are inserted surgically through an incision in the abdomen into the stomach. Some examples of G tube names include the Mickey button and percutaneous endoscopic gastrostomy PEG tube. A jejunostomy J tube is inserted surgically through an incision in the abdomen into the jejunum, the middle portion of the small intestine. At times, these devices can become dislodged or bleeding may occur. Such patients should be transported to the emergency room for treatment and possible replacement of the tube. Follow local protocols for care and hemorrhage control. Patients and caregivers are usually comfortable with and knowledgeable about these devices. In many instances, they will be able to answer questions and can lend assistance to EMS providers. A urinary catheter, also called a Foley or indwelling catheter, includes a sterile tube that is inserted through the ureter into the bladder to drain urine for patients that have lost control of their bladders or the ability to urinate on their own. The tubing is connected to a collection device such as a bag strapped to the patient's leg or a larger drainage bag that may hang on the side of the patient's bed. Common problems with urinary catheters include infection, catheter blockage that prevents urinary drainage, and catheter dislodgement. During transport, keep the drainage device below the level of the patient and be careful not to damage the bag. Being terminally ill means the patient has a disease or illness that cannot be adequately treated or cured, ultimately resulting in the individual's death. Terminally ill patients may have cancer, heart or kidney failure, AIDS, or other progressive diseases such as Huntington's or Lou Gehrig's disease. Hospice care focuses on palliative care, which is medical care designed to relieve or prevent suffering. This is different from curative care, which is designed to cure the underlying disease. Healthcare professionals and volunteers providing palliative care focus on end-of-life care with the goal of offering the patient peace, comfort, and dignity. Terminally ill patients may have do not resuscitate orders in the form of a bracelet or other written orders such as a living will or a healthcare power of attorney. More information on these various advanced directives is provided in the medical legal module of this course. Follow your local protocols when DNR orders or other advanced directives are a factor in providing care. Do not hesitate to contact your medical control if questions arise on a call. Also remember that just because no life-sustaining treatment during cardiac or respiratory arrest should be provided, it does not mean no treatment should be given at all. Comfort care measures, such as oxygen administration or airway suctioning, are allowed. Treatment for unrelated conditions is also allowed. Compassion, understanding, sensitivity, and professionalism should be displayed throughout all patient encounters, but even more so with the terminally ill patient. Remember as well that friends or relatives of the terminally ill patient may require the same type of consideration from the EMS provider as the patient him or herself. If responding to a hospice care patient who proves to be dead, be certain to follow your local protocols in handling and documenting the response. Another population faced with challenges are those with sensory defects, which commonly include either visual or hearing impairments. When interacting with patients that have a visual impairment, keep in mind that the degree of impairment, along with the person's ability to adjust to the impairment, are the most pertinent factors for living an independent, active life. Never assume such a person is dependent on others. It is better to ask questions to clarify how independent they are and just what type of assistance they need. Possible causes of visual impairment include diseases such as glaucoma or diabetic retinopathy, injury caused by trauma or burns, infection, congenital conditions such as prematurity or cerebral palsy, or degeneration of the eyeball, optic nerve, or nerve pathways. Accommodations for the visually impaired patient may include canes, eyeglasses, other assistive devices, guide or service dogs, or the patient may simply prefer to hold on to the provider's arm. It is important to remember to ask permission before touching a guide or service dog. The patient may prefer that people do not pet the dog when it is working or in a harness. Another consideration will be transportation of the dog. If circumstances and protocols allow, the dog should be transported with the owner. When approaching the visually impaired patient, let him or her know you are there and describe what you are doing. Verbalize your actions, treatments, and explain environmental information. Also be sure to bring the patient's assistive devices with him in the ambulance and be certain to leave them at the hospital with the patient. Hearing impairments involve a decrease or loss in a person's ability to hear. The auditory disability may range from a slight hearing loss to being completely deaf in either one or both ears. If the disability is in only one ear, be certain to speak into the patient's unaffected or less impaired ear. Possible causes of permanent or temporary hearing impairment include congenital conditions such as malformation or defects, infection, especially in pediatric patients, injury caused by trauma or repeated loud noise, drugs such as furosemide, gentamicin, or aspirin toxicity, illness or disease such as maternal rubella or bacterial or viral meningitis, tumors, or recent airline flight, deep water diving, impacted earwax, or temporary blockage sometimes caused by a hematoma or foreign bodies. Accommodations for the hearing impaired patient may include hearing aids, an ear microphone, telecommunication devices for the deaf, TDD, text telephone, or teletypewriter, TYY devices. The person may use sign language, rely on lip reading, or use a writing board. When assessing the patient, face them so they can read your lips, speak slowly in a normal voice, make sure the environment has adequate lighting and background noise is reduced. Help them find their assistive devices as needed, such as hearing aids, or provide a pen and paper for communication. Utilize the assistance of family members as they have usually adapted to the patient's hearing impairment, and anticipate the need for a sign language interpreter if feasible or available. Resist the temptation to yell or exaggerate your responses, as the patient may misinterpret your actions as anger or impatience. Many partially deaf people do better with low-pitched voices, so attempt to speak in a deep voice if possible. Before transporting, be sure the patient has his or her assistive devices. Home care is health care or supportive care provided within a patient's home environment. Patients can range in age from infants to the elderly, although they are commonly over age 65. These patients may include those with chronic illness, developmental disabilities, or a dependence on medical devices. The patient's special needs may result from conditions such as multiple sclerosis, brain injuries, or the need to be on a ventilator. Home care services may include meal delivery or preparation, cleaning, physical therapy, bathing, or wound care. Home health care personnel may be volunteers, certified nursing assistants, nurses, or other trained medical or non-medical workers. Home care providers are commonly very familiar with their patients. Do not hesitate to ask them about the patient's baseline status, medical history, medications, or other pertinent information. Developmental disabilities occur when the brain does not develop properly, resulting in dysfunction and impairment. Over an average career, EMS providers will encounter both pediatric and adult patients with developmental disabilities. Autism is a developmental disorder that affects the brain's development as it relates to social and communication skills. Patients with autism have problems with communication and social interaction. Patients may have behavioral problems, repetitive motor activities, or impaired verbal and nonverbal skills. There are many theories as to what causes autism, but no definitive cause has been found. Patients with autism have varying levels of disability. When performing an assessment of an autistic patient, attempt to keep questions and tasks simple and utilize the patient's family or caregiver when available. Down syndrome, also known as trisomy 21, is a genetic condition caused by a chromosomal defect that results in mild to severe mental retardation and disability. Recognizable physical features, slowed physical development, and delayed mental and social development are typical for patients with Down syndrome. These patients are also at an increased risk for medical problems. For instance, more than half are born with congenital heart defects. The level of disability will vary from patient to patient, which will require the EMS provider to individualize the way in which he or she provides treatment to various Down syndrome patients. Developmental disabilities may also result from brain injury caused by trauma or an oxygen deficiency. These patients may prove difficult to assess and treat. Utilize information provided from the patient and family to determine what behavior is considered normal for the patient. Attempt to identify what deficits the patient has, explain procedures, and reassure the patient throughout the entire assessment and treatment process. As an EMS provider, remember to be professional and respectful of patients with developmental disabilities. Do not hesitate to utilize the patient's family, caregivers, or friends in providing assistance or obtaining information about the patient. Take special care to provide explanations and watch for signs of anxiety and agitation. Also attempt to calm and reassure the patient. Physical disabilities includes a broad range of ailments that often result in patients relying on assistive devices and/or others for mobility. These disabilities may be congenital in nature or can occur as a result of injury or infection. Cerebral palsy is an umbrella term for a group of disorders that affect the functions of the brain and nervous system. It is characterized by poorly controlled body movements, such as spastic movements, and can result from brain defects during development in utero, brain injuries at birth or in childhood, or from infections such as meningitis in the neonate or infant. Patients with cerebral palsy have varying degrees of difficulty with movement, learning, hearing, seeing, and thinking. These patients may also have other conditions, such as epilepsy and mental retardation. When caring for patients with cerebral palsy, start by assessing their airway and breathing, as these patients may have excess secretions or difficulty swallowing, which may require intervention. Spina bifida is a developmental congenital disorder caused by the incomplete closure of the spinal column that often results in the exposure of the sac that surrounds the spinal cord. Related disabilities often include partial or complete paralysis of the lower extremities, along with a lack of bowel and bladder control. Many patients born with spina bifida also have hydrocephalus at birth, which is a buildup of the cerebrospinal fluid in the skull that leads to brain swelling. Ventriculoatrial or ventricular peritoneal shunts may be placed in these patients to drain excess cerebrospinal fluid. It is not uncommon for patients with spina bifida to have a severe allergy to latex. Use latex precautions when working with these patients. Paralysis is the loss of voluntary movement of one or more body parts. The types of paralysis are hemiplegia, which is paralysis of one side of the body, paraplegia, which is paralysis of the lower part of the body, and quadriplegia, which is paralysis of all four extremities and the torso. Paralysis may result from a stroke, injury, or birth defect. Although patients lose voluntary movement, it is important to remember this does not necessarily mean they have loss of sensation to the affected area or body parts. Patients with paralysis may also have specialized medical equipment and devices, such as tracheostomies, ventilators, urinary catheters, colostomies, or feeding tubes. Use caution when lifting and moving patients with paralysis, as they may not always be able to tell you if a movement or procedure produced pain. As with other patients with special challenges, family members and caregivers can be great resources during assessment and treatment. Cystic fibrosis is an inherited genetic disorder that primarily involves the lungs and digestive system. Thick mucus forms in the lung and pancreas, leading to respiratory and digestive problems. These patients are at risk for recurrent lung infections and malnutrition. This condition carries a poor prognosis, and many patients with cystic fibrosis do not live past their 30s. Given the nature of this disease, remember to assess the airway, breathing, and circulation in these patients. Oxygen administration and suctioning may be necessary for comfort and to clear thick secretions. Multiple sclerosis, MS, is a disorder that affects the central nervous system, the brain and spinal cord. The protective covering on nerve cells is damaged by inflammation. This damage causes the nerve signals to slow down or stop, leading to symptoms such as muscle weakness, difficulty ambulating, and speech or visual problems. The exact cause of MS is unknown. Muscular dystrophy is a group of inherited genetic disorders resulting in progressive muscle weakness and loss of muscle tissue. Complications may involve frequent falls, inability to move and care for oneself, and problems arising from impairment of respiratory and cardiac supportive muscles. EMS providers must be professional, respectful, and compassionate when caring for patients with physical disabilities. Family, caregivers, and friends can be valuable resources when caring for these patients. Ask questions to determine the patient's baseline functioning status and do not assume he or she is fully dependent on others. Remember to transport medications and assistive devices to the hospital along with the patient. Given your completion of this module, you should now be able to list the types of abuse found in the pediatric and geriatric populations, summarize the assessment and management of pediatric and elder abuse patients, explain the legal ramifications of failing to report abuse, describe the documentation needed for abuse patients, relate to patients with sensory defects and utilize enhanced communication skills, prepare to interact with the developmentally disabled patient, give examples of health issues for which the bariatric patient is at increased risk, recognize the increased planning necessary to move bariatric patients, identify technology-assisted or dependent equipment used by patients, explain what a tracheostomy is and the routine and acute care which may be necessary, describe the interaction with patients being provided healthcare at home, summarize the concept of hospice and the EMS role with patients under hospice care, and identify the potential assistance that can be provided for homeless patients. You should also be able to explain the rationale for having skills and knowledge appropriate for dealing with patients that have special challenges. Recognize the importance of including family members and other healthcare providers in the assessment and management of patients with special challenges. Attend to the feelings of the family when dealing with patients who have special challenges, and understand the provider's own emotional response to caring for patients with special challenges. Lastly, you should now be able to demonstrate the interview and assessment of a patient with sensory or cognitive defects. This presentation was created by Waukesha County Technical College with grant funding from the Wisconsin Technical College System.